Good evening, everyone, and a very warm welcome to all the delegates. Thank you. Thank you all for joining in. And I'm very excited to bring in the abdominal ultrasound skill advancement is the foundation of ultrasound imaging that actually is for in terms of diagnosis, in terms of the fundamentals, and each and everything. And it's as vast as it can be, and it's got a great potential in diagnosis. If we are really putting in all the attention to the details, we can really create wonders with the ultrasound probe. So join me all, and for the full course, this is just an attempt to share a little preview for the course. I'll begin with sharing my slide. 1 second, allow me to do that. So yes, so my slide is visible, and I'll just get to the slideshow. Second slideshow from the beginning. Okay, so ultrasound and abdominal emergencies. Now, basically, I think each and every patient is provided it's just about the illness of the timeline of the illness, right? We are basically looking and addressing a particular area of concern, or sometimes very vague. Now, the spectrum is huge, and it will totally depend upon the age of the patient, the gender of the patient, the background of the patient, and the various trauma, non-traumatic, and various other vitals and parameters. And it will all guide you as to which is the target area. However, each examination is a complete and a thorough examination. This importance cannot be just underemphasized. It's just sometimes you think out of the box and oh, this was the pathology. That is so interesting. So really, I urge you all to do a thorough, complete abdominal scan, even though the request is for a particular targeted area. Do run your probe like if you like in the study protocol, there's always a survey scan, and then each and every organ examination scan. So regardless of whatever is the billing code, regardless of whatever is the request, always a complete scan. Okay, now as a radiologist, we look at abdominal ultrasound in details. We always go step by step and look at every organ. For emergency physicians, abdominal ultrasound means differently. For other people, it means differently. So basically, this is an area of overlap between various imaging physicians who are all working together to do this. Right? We together are working in the holistic approach to the well being of the patient. Now, this is a focus point of care ultrasound. Don't know that we don't even know, even though we've been scanning for a very long time. So, of course, a lot cannot be covered in this session. However, I will try and give a little insight into it. Thank you. So now, as I discussed, it's now a core skill for emergency physicians. We will just give a reference to the POCUS guidelines set by the American College of Emergency Physicians, ACEP guidelines, right? Now, basically, approach for an ultrasound abdomen has got to be systemic and focused and specific to the patient system. So what does it mean? You will just do a specific targeted scan? No, it has to still be systematic, thorough, and then you come back to the key area of clinical concern, and then you again come back to the specific symptomatology of the patient. So basically, it is detailed, it's comprehensive, it's horizontally and it's wide, and it is targeted and vertically, like deep down, focused as well. So different protocols for different patient symptoms under ACEP clinical guidelines have been proposed. like symptom or sign-based ultrasound. For example, fast ultrasound protocol for a trauma patient, which is focused assessment with sonography in a trauma patient, or a rush protocol for a hypotensive patient, which is rapid ultrasonography for a shock and hypotension patient, or a blue protocol for a dyspnea patient, which is a bedside lung ultrasound in emergency. And here we are going to look at the acute abdomen protocol, which is done when done in a proposed systemic approach, provides the key information in the shortest time span, which is what we want. We want to quickly figure out whether we want to take to the OT, to the further imaging, or manage symptomatically. So let's understand what is this acute abdomen protocol. Okay, now let's understand. So acute means A for abdominal aortic aneurysm. A for abdominal aortic aneurysm, C for collapsed vena cava, U for ulcer or perforated viscous or pneumoperitoneum or any abdominal visceral rupture, T for trauma for fluid, and E for ectopic pregnancy. And the abdomen, the A stands for appendicitis, B for biliary tract pathologies, D for distended bowel loops, obstruction, O for obstructive uropathy, urinary tract abnormalities, and the men, in case of men, for testicular torsion, and women for ovarian torsion. Okay, so it kind of sums up all. And of course, there's pancreatitis, there are various other things. I would include one others, which will have a bigger umbrella of lots of things that are not included in this, right? So as we go step by step, we'll understand things more. Now, ultrasound in acute abdominal aortic aneurysm. We'll just cover these broader headings, a summary, and then we will try and cover up one area in details so as to give you an understanding how to approach. And the detailed area is very intense, right? The pathology, it's like a complete clinical radiology that we have to understand and go for it. Now, abdominal aortic aneurysm. Can physical examination identify when the clinician are examining? Very few cases, unless the patient is a lean thin, they can palpate, they can suspect, and then they can send for imaging, right? Which happens less often, right? Ultrasound by emergency physicians or by routine abdominal scan can detect in 93 to 100% of cases with specificities approaching 100%. Now, how many of us are actually evaluating abdominal aorta right from the diaphragm height as T12 level down to its bifurcation in each and every patient? Simple test, it can actually do wonders in the patient outcome. And I was actually very surprised to see the data of the amount of, it's 25% of only 25% of patients will present with classic triad of abdominal pain, hypertension, and versatile mass. And when the ballooning of aorta leads to rupture, like when it's more than 5 or 7 centimeter diameter, the results are catastrophic. And it's the 13th leading cause of death in the US. So this just shows that our thorough abdominal ultrasound has such a big role in the diagnosis and management. However, in an emergency setting, obviously, what we will see is a dilated aorta. We can see a true lumen and a false lumen. We can see a saccular or a fusiform aneurysm, and we can also see a dissecting aneurysm where we can see a moving flap in the lumen and two circulations going on. Of course, ultrasound will use a curvy transducer or the higher frequency transducer, whatever gives us the best information, scanning long and short axis, right from epigastrium till the bifurcation. And of course, routinely, abdominal diameters are around 2 centimeters, and 2 to 3 are upper sides, and more than 3, of course, we call it abnormal. And then, of course, most common site for an aneurysm is below the level of the arteries, below the level of the renal arteries. And ultrasound is accurate, safe, non-invasive. And like I already discussed, it's a significant mortality to this, so undiagnosed. And classic triad is seen in few. So normally, I said 2 centimeters or less, and repair or surgery is usually not considered until more than 5 centimeters. And then, of course, when surgery is not done, we are periodically following it. So we have to measure the diameter, and of course, we measure outer to outer and include any thrombus as well in the measurement, right? Okay, now coming to um, this is how we look at the anatomy. We go all the way from top, look at the bifurcation of the arteries and go up to the iliac arteries, and sequentially the branches that we see for the aorta, celiac artery, SMA, the renal, gonadal, and the inferior mesenteric artery we see. Okay. Now, the second that they said was acute collapsed inferior vena cava and acute hypertension and shock. So we are used to looking at aorta. Are we looking at the IVC? We can look at the diameter in inspiration and expiration and see the difference in the diameter. So IVC collapsing when there's more than 50% difference in the diameter in the inspiration and the expiration. So according to the updated American European guidelines, an IVC diameter or less than or equal to 2 centimeters and a collapsibility of more than 50% during inspiration suggest the right atrial pressure between 0 to 5 millimeter mercury, however, a diameter of 2.1 centimeter more with less than 50% inspiratory collapse indicates a high RAP of 10 to 20 millimeters of mercury. So that gives you a cue of the hemodynamic status. So of course, you will measure the diameter. That's you measure in here, and then you measure in the different phases of respiration, and you calculate the collapsibility ratio. Now, next, ACU. U is the ulcerated or the perforated viscous, so leading to pneumopoietum. So basically here we are trying to diagnose if there is a free gas, free air in the peritoneum. Now, how do we sense that there is? Obviously, when there's a lot of free gas, the first thing that you will see that I put my transducer, I can't see anything. That just like hits you. I can't see anything because the free gas that you are seeing and gas is lighter, so would obviously be at the top in a supine patient. When you put it, it will be very challenging for you to see. However, you can move the patient around and try and see it from different angles and maneuvers. You can still do some scanning, right? So 2 direct signs and there are 4 indirect signs. Now, what are the 2 direct signs? One is the enhanced peritoneal stripe sign or the echogenicity of the line of the peritoneum. We'll understand that. Second, we see the A lines, which you normally see in the lung, which now we will see them in the peritoneum, and I will understand a little bit about it. And of course, indirect signs you will see is intraperitoneal free fluid, associated signs, air bubbles in the ascitic fluid, thickened bowel loops, any pathology, bowel or gallbladder thickened with ileus and obstruction and stasis and paralytic ileus and other factors, right? So let's understand what is this EPSS and what are these A lines in the peritoneum. Now, if you look at this little thing here, do you think this is a normal finding? Very tiny, very subtle. Something, if you just pay attention to this. Now I'm going to put on a little clip here. So what it's saying is identification of focal hyperechogenic thickening of the peritoneum, associated posterior dirty acoustic shadowing. And then you also see the horizontal reverberation artifacts, which you will see. And the gas bubble, which is there, the corresponding reverberation artifact. So subtle signs that you see, these are suggestive of free air. So be aware of these in a setting of high index of suspicion of perforation of rupture. Now, normally, you do not see that much of echogenicity of the peritoneal stripe. What happens is, what happens is the air within the peritoneal CS rises and causes enhanced peritoneal stripe sign. So normally the ultrasound waves course through the interior abdominal wall into the peritoneal fluid and results in a thin peritoneal stripe. But in the setting of the free air in the abdomen, the ultrasound waves are interrupted after passing through the interior abdominal wall, and this causes scattering of the ultrasound waves, resulting in a high amplitude linear echoes, causing an enhancement or echogenicity of the normal peritoneum. So this leads to this echogenic appearance of the peritoneum and the peritoneal stripe sign. So other ways, the interface between the gas and the soft tissue is highlighted. So when you see that kind of an appearance, you suspect free gas. And of course, and those areas and shadowing of the, you will see the reverberation artifacts deeper to this and which lead to these A lines, which you normally see in the lung parenchyma. So again, that points out to appearance of echogenic pneumoperitoneum. And just to recap, this is how a normal looks. So we have a normal smooth A line, and the air is normally just seen enclosed within a bowel viscous, right? No free air, right? Okay, right. Coming to this next, so this is again the peritoneal stripe and then the A lines which are seen, right? Now, the ACUT. Now coming to the T, what is the T? Of course, trauma. Trauma, the first thing we are looking at is free fluid, and then we send the patient up for CT. That's what we often do, right? So where do we look for the free fluid? Obviously, free fluid, usually we look at tiny little in the Morrison's pouch, or we look in the dependent pharmacies, dependent areas, right? So of course, fast scan is what is quickly done. The right and left paracolic, pericardial region, suprapubic region, and the anterior thorax and additional views. We have to look for it. So the right upper quadrant, left upper quadrant, suprapubic, pericardial, and anterior thoracic. And of course, you can add on to scan in the right and the left paracolic region. So we are trying to look for the fluid, right? So you can just have a look at see if there's any fluid here. The Morrison's pouch looks clear here, not much fluid here. Now here there's another case where you have trauma, you have fluid, and you have echoes in the pleural space. So this is right hydrohemothorax, there's hematoma, there's fluid, there's this. Okay. Now, this is just the algorithm, and first the locations, like I just said, right or the left, upper quadrant, and the pericardial, suprapubic, and you have additional views of the chest and the epigastrium. Now, this is just a little algorithm. So trauma, unstable patient, you'll quickly see the fast scans and use fluid plus positive findings. You take the patient up for surgery. Or imaging, depending for the CT. Stable patient, again, plus positive findings, you can do a CT. Again, stable patient, you can, depending on the clinical, you can observe or CT or contrast ultrasound if there's a subtle trauma or a laceration, which is not so obvious on routine ultrasound. It can be picked up on contrast or a CT, depending on the clinical picture. And of course, these are the other findings. You'll see effusion and other things, hepatic lacerations that you can see. You see heterogeneous parenchyma and surrounding fluid and hematoma and lacerations, right? Okay. And spleen, again, you see heterogeneous parenchyma with hematoma, classic, and of course, flow changes you will see. So, coming to the next, we've done trauma. So acute abdomen, now distended bowel loops, right? Okay. So distended bowel loops, so abdomen. Okay. So small bowel obstruction. We have the mnemonic of the diameters of the bowel. So we will look at the diameter, thickness, and we'll see more so for the motility and the movement of the contents. And if there is any reverse movement, back and forth movement of the echoes inside the fluid, meaning, so like we will learn more in detail when we do interception. So contents are going and then they are coming back. So And of course, there's some stasis or ileus or decreased peristalsis that's also happening. So you look at that and yeah. And of course, you will scan all the areas. Now coming to what, I'm just going to plot this here. Okay. Obstructive uropathy, we all do it so frequently, it doesn't require much of an attention in this. Of course, there's a full detailed module on renal in one of the modules. The whole course content has already been posted on the website. Hydronephrosis, you will see dilated renal calyces, you can see the calculi, you can see the twinkling artifact on the color Doppler, or a dense shadowing or a soft shadowing. And of course, you'll use different transducers depending upon the frequency, depth, resolution combination. And you will, of course, advise, you scan in different positions. Of course, hydration is important. There may be post-op, there may be limitations, there may be obesity, there may be gas, unprepared. Various challenges will be there. However, that's what we are there for. Okay. All right. Of course, testicular torsion for men and ovarian torsion for women. So can be seen in any age group. I've seen in young boys and girls as well. So be open to possibilities of the wide spectrum of diagnosis. And I saw torsion recently in a 9-year-old female. So yeah, you can see them at any age. So that's very important to be aware of the possibilities and be open to the possibilities in the diagnosis. Okay, so next we go to, right. So having this overall perspective, right? Now, acute abdomen, as we know, like there's a lot. So in adults, I would say, what is it? You see pancreatitis, you see renal calculi, you see gallstones, you see renal, you see, like I discussed, perforation, fluid, you can see mesenteric ischemia, you can see thrombosis, you can see these are the common things that, of course, post-transplant patients, hepatic artery thrombosis, you will see renal transplant failure, recent renal transplant patients or long-standing transplant patients, you can see thrombosis or arterial or venous, right? So the plethora is huge, right? Now, what can I cover up to say? Now, an area which my colleague said the most challenging is, of course, to look at the bowel in ultrasound, right? And to look at the bowel in the pediatric age group is another bigger challenge, right? So looking for acute appendicitis, looking for bowel abnormalities on the ultrasound imaging in acute abdomen, people would say, oh, go for CT. This is a domain of CT scan. However, it's possible to do it on ultrasound. We have to be open to it. We have to just remember the anatomy. We have to remember that we have a probe and it works on a certain scientific principle. We need to just shift the gas and we need to evaluate in detail and we can get the diagnosis. It is possible. You all agree? Next time, before we send our patients to CT, have we justified by doing a very good ultrasound first? There are lots of answers we get. Like, I mean, subtle metastatic nodules also when you pick up and then when you send for images, when your CT colleague tells you, wow, that was a very nice pic. So the more you are step by step and thorough, the more you cover and the more you feel more confident and you feel you're doing a great job. I think that's very important. As an ultrasound physician, I feel like to be very thorough and to be very systematic in my approach really gives me big, big rewards. Thank you. So GI emergencies in children and neonates are a dilemma for a radiologist. You would all agree. Yes? Child can't communicate, kahan par dard hai, we do not know what's the pain area, we do not know, child may be conscious, non-conscious, not responding, sleeping, not sleeping, crying, various challenges, anxiety of parents, everything, doctor, what to do, can't do too much of CT again and again, there is a pain, what to do, right? A lot is on the shoulders of the ultrasound and a lot is on the shoulders of the person who's holding the probe, right? So let's simplify it. Are you all in? Okay. However, once we recognize they do present with a spectrum of characteristic ultrasound features, and it is simply a learning curve. Learn it, practice it, learn it again, practice it again. Learn it again and practice again. And the more we practice, we get better at it, right? So why is the dilemma? Like I said, pain is common presentation. We often do not have a complete history. Atypical clinical presentations can surprise you. Numerous extra abdominal causes are there as differential, and the evaluation of painful abdomen in children often causes difficulty in arising and causes a diagnostic dilemma. So let's understand. We have to what is the urge of diagnosis, right? In any situation. Okay, is this something that we really need to take for surgery right away? Or do we can just manage it medically? So those crying areas are areas where we really need to be able to separate. I mean, something that needed an urgent surgical attention, like a torsion of testes or epididymis or a rupture of ectopic pregnancy, or those are the things like, we must be able to diagnose, like, you feel like, okay. So here, like trauma and medical conditions, we've covered a bit of trauma already, and ultrasound is a primary tool. Common emergencies in GIT in the pediatric age group are appendicitis, intussusceptions, hypertrophic pyloric stenosis, volvulus, diverticulitis, others, right? Now let's see. Depending on the age of the child, you would think of the differentials in the diagnosis, right? So the approach to a pediatric acute abdomen for 0 to 2 years of age, the surgical differential diagnoses are intussusception, malrotation, pyloric stenosis, duodenal obstruction, and incarcerated hernia. Of course, all these have their specific clinical symptomatology, so it's very important to look at those if they've been written very well for you. Intussusception, classic recurrent jelly stools, malrotation, vomiting, distension, pyloric stenosis, projectile non-bilious vomiting, duodenal obstruction, bilious vomiting, and incarcerated hernia, swelling in the inguinal area and distension. Right. So the most common etiologies are, of course, non-surgical gastroenteritis. You might just see some small mesenteric lymph nodes and UTI and viral illnesses, right? Now, coming to the 2 to 5 age year group. So often the type and the location of the pain might just give you an insight as to where are you looking at. So of course, the surgical differential diagnoses are acute appendicitis, intussusception, malrotation, and other causes. Hepatitis, pyelonephritis, constipation, mesenteric vaginitis are also in the picture. Coming to pediatric acute abdomen, in the 5 to 12 years age, you have acute appendicitis, intussusception, volvulus, and intestinal obstruction. Now, older than 12, we almost reach the adult age group. So, of course, all the others, renal, urethral torsion, ectopic, and extra-abdominal causes come into picture. And of course, always remember cholecystitis, cholelitical pancreatitis, Meckel's diverticulitis, abscesses, and ectopic. Now, coming to acute appendicitis, one of the very commonest causes of acute abdomen, spanning all ages, to be honest. Of course, very common in pediatric age group. Various transducers are used depending upon the age and the habitus of the child, with an aim to use the highest frequency to get the required depth of penetration and resolution. 3.5 megahertz and 7.5 megahertz transducer, longitudinal and transverse axis scan combined with color Doppler, and we use classically a graded compression technique. What it is, basically, you just move your probe gently to displace the air so we can actually evaluate the bowel very well. Now, why is that important? Because, the bowel will not let you see. You may be able to see the interior bowel wall, but if you displace the bowel, the air, then you can see the posterior bowel wall as well. So let's understand the normal cut signature. So, of course, we have the normal cut, which has got the innermost portion, the lumen, then the first layer, hyperechoic, is the mucosa, then second hyperechoic is the muscular layer, then again, you have muscular layer and then hyperechoic layer. So accordingly, you have these longitudinal, circular muscles and all these layers that you can understand and appreciate. Nice symmetrical outline, no focal lesion, no thickening and no focal thickening, no asymmetry. All those features you can instantly wake up. And on cross section, you'll see a classic target sign kind of an appearance, right? So with this understanding of the normal, let's look at the abnormal, the acute appendicitis. Commonest cause of acute surgical abdomen in children. Presents with right lower abdominal pain, or often most people these days have periumbilical pain, vomiting, fever, leukocytosis. Ultrasound is important in diagnosis, seeing the complication, follow-up of complications, and post-follow-up. So it's very, very important to have a great grip of understanding of appendicitis, right? Graded compression technique. And how does an inflamed appendix look like? Aperistaltic, non-compressible, thick wall, more than 6 millimeters in diameter, hyperemic, tubular structure, and you may see an appendicular nutshell, right? Of course, echogenic periappendicular fat stranding, pupillus, and free fluid can also be seen. So acute appendicitis typically develops in older children and young adults, rare under the age of 2, and presents a challenge because it has to be differentiated from other conditions in acute abdominal condition, which could be managed symptomatically, and this may often require an urgent surgery, right? Classically, we know this picture, we've seen it. Classical appearance of a tubular dilated structure, echogenic wall, non-compressible, and that's the transverse image. And these symptoms we've already discussed. Ultrasound is highly accurate in the diagnosis. And of course, if we do it well, we have a good diagnosis. Graded compression techniques. So gentle gradual pressure is applied to compress the interior abdominal wall, resulting in displacement and compression of the normal bowel loops. Adequate compression is achieved if the iliac vessels and the swab muscles are seen, since the appendix will usually be anterior to these structures. And of course, you scan in various planes and various orientation of the patient with various transducers to get the best possible diagnosis, right? You can begin with the identification of the ascending colon, and then you move it inferiorly to identify the terminal ileum, and then you expedite to the, and you can extend for various anatomical positions of appendix, whatever you can. And like I discussed, so tubular, non-fluid filled, non-compressible blind ending structure that you can see, a target sign, various appearances that you can see. Okay, so appendicolith appears as an echogenic focus with shadowing, and you can have associated finding of eccentric lymph nodes. So summary, of course, diameters more than 6 mm, maximum tenderness point coinciding with it, incompressibility of the appendix, inflamed appendicolith, hypervascularity on color Doppler, and loss of stratification of the normal appearance of the appendix wall, right? So like here, you can have calculate the tip, you can see that and see the amount of appendicular fat inflammation, the echogenicity. So this is another important finding that you must give. So again, you have a sludge and you have a calculus, and there's a dilatation distal to the obstruction. Again, echogenic shadowing and calculi. So secondary signs are the hyperechoic periappendicular fat tissue, complex fluid collection, abscesses, and reactive fluid. Now, coming to the complications, and they may present in acute abdomen, right? Patient may have an outside report, patient may already been diagnosed, and patient is on symptomatic management, supportive management, and suddenly patient may deteriorate and undergone perforation and has come to you. So looking at the clinicals is also very important, and you have to be prepared perforation, abscess formation, lump formation, intestinal obstruction. Can we diagnose them on ultrasound? Yes, we can. Let's understand. So, ultrasound features suggesting perforation. What are they? Loss of the echogenic submucosal layer, presence of loculated periappendicular or pelvic fluid collection or abscess. So this is classic. You'll see a lump or a collection in the area and in the vicinity, and which is often tender. And adjacent bowel loops may show some interbowel fluid or decreased peristalsis or stasis as well. Color Doppler, is there any role? Yes, it helps. So it demonstrates peripheral wall hyperemia, reflecting inflammatory hyperperfusion. So in early inflammation, the color flow may be absent or limited to the tip, and it may also be absent when it's just undergoing gangrene, right? So the color Doppler findings include hyperemia in the periappendicular soft tissues as well, or within a well-defined abscess. So that could also show enhancement, right? So like you can see the amount of pus collection and you see the amount of enhancement of the wall, right? Inflammatory hyperperfusion and thick collection. So not very good finding, right? And this is just a panoramic view showing the appendix with calculi and shadowing. And I'm really grateful to my colleagues for the wonderful images that they've shared with me to share with all of you. Thank you so much. And again, a panoramic view, which is showing the calculi and the shadowing of the organs. So again, you have a appendix and transverse view. And again, this one is a very long appendix. So sometimes we think we've seen it all, but it's very important to see to the tip. There may be loss of vascularity at the tip. There may be a setting in of gangrene at the tip. So it's very important to reach the very tip on the ultrasound imaging. Okay, now next. So you will see, so that's why it's important to scan the entire length. You can see appendicular leg or perforation or a abscess formation just in the very tip. There could be a little leak and there could be a collection. So here we have a case of perforation and an abscess formation. You can see there is a collection that has developed and which is very easy to see, and it's obviously tender and it's obviously confirmed at surgery, right? Now, another case of perforation and a lump, you can see a heterogeneous hypoechoic mass with, of course, some vascularity. Associated findings we discussed, we can have eccentric lymph nodes, inflammatory lymph nodes, and then you can also have because diverticulitis and infectious ileocystitis and other syndromes, right? And these are just the details about the full course. The full course covers, there are 12 sessions to aim to do 2 a month, covering entire whole abdomen. I'll explain about the details later. Now, let's come to another important acute abdominal emergency that you can come across in a pediatric age group related to the GIT, which is intussusception. Entirely in ultrasound diagnosis, and also ultrasound is often used in management of the same. So, commonly between the age of 2 to 6 months to 2 years. And what happens is a portion of the GIT becomes telescoped into the adjacent bowel segment. Okay, so a portion of the GIT just becomes telescoped into the adjacent GIT. So there is an advancing segment, there is a coming out segment. Vast majority are ileocolic. So classical symptomatology is, of course, current jelly stools, blood per NS, and a palpable mass that can be felt. Ultrasound, of course, has got a very, very high sensitivity and specificity. So, like I said, the intussuscipiens, the receiving loop, contains the four-dict intussusceptive, the donor loop, and which has the two components, the entering limb and the returning limb. right? So this is how we see, and of course, this is how it would look like in a transverse section if you were to cut it through at the point where you have all the bowel loops there. And accordingly, depending upon where we get the transverse section in the imaging, you will be seeing that findings will vary whether the section has been obtained at the apex or at the near the base or in the middle area. So at the base, you will find a hyperechoic ring, and I think that would take it to a lot more detail. And classically, in longitudinal scan, you'll see a sandwich sign, right? Based on the bowel walls, then inside and outside, right? So how is the sandwich sign formed? With the three parallel hyperechoic bands separated by two nearly hyperechoic bands and representing the various balls. So that's the same here on color Doppler, because it's all, you will have a twisting of the vessels that you'll be able to appreciate. That will give you a cue. Longitudinal scan, the typical sandwich sign or the pseudo kidney signs, right? Now, like we already did the symptomatology, it's often used in the, these are more of some images, and we can use it for ultrasound as a therapeutic as well, but I think I will move on to the lead point. Of course, could be infectious lymph nodes or prominent Peyer's patches, right? So this here, there was a lead point. This was a lesion, a mass lesion. So here you can see there's an inflammatory lesion, which has become a lead point, which is causing the bowel obstruction. Of course, would require a surgery. And that's the color Doppler of the same case. And I'm thankful to my colleagues for the wonderful images. So again, you can have these, so leading to the intussusception. You can go for a hydrostatic reduction. We will leave that for the this course. We'll, of course, discuss all that in the detailed class, right? So coming to the hypertrophic pyloric stenosis in the neonates, of course, in the first week, you'll see infant presenting with projectile vomiting. And of course, what you will see is a bullseye sign. And you look at the thickness of the pylorus and the length of the pylorus. So you look at the thickness of the pylorus, the donut sign, and you look at the length of the pylorus. So how do we do it? So that's the length of the pylorus, and that is the thickness of the pylorus. So we measure these things. So thickness of the circular muscle, not more than 3. And we look at the length as well, right? So here you can have dimensions in the middle and more. We will look at it in more detail. Coming to the next. So these are again images which we will discuss. You can have minimal pylorospasm in other cases, duodenal obstruction and other abnormalities you can have. And you can have other causes of bowel obstruction, which will vary depending upon the age of the patient and the presentation. So you can have altered relationship between the blood vessels in midgut volvulus, and you can demonstrate the mesenteric twist and the whirlpool sign of the SMA and the SMV altered configuration. And these are, of course, will require a CT to confirm, but ultrasound, when you see the back and forth, back and forth, back and forth. So that gives you an cue that you may be looking at obstruction of the contents going forward. And accordingly, you can direct appropriate imaging further. That will direct appropriate imaging further. Okay. As a role of ultrasound physician, that's what we primarily have to do. Rarely you're surprised with other bombs and classic pictures on our ultrasound. Incarcerated indirect inguinal hernias. You may present with groin pain. There could be a hernia which could be just stuck and strangulated. And of course, can be seen in any age group, pediatric or adult age group. Of course, the biliary tract abnormalities, acute cholecystitis, calculi, stones, thickened wall, rupture, perforation, GB, abscess. All these things can be seen. Choledochal cyst, stones in the choledochal cyst, dilatation of IHPR, various other abnormalities can also be seen. We will obviously look at all these in extensive detail in their specific modules as we do our skill advancement to learning and relearning abdominal ultrasound with all the current guidelines, updates, and interesting cases added to really stimulate the minds. Thank you. And I'm very much ready for all your questions and make it an exciting, interactive journey to relearn abdominal ultrasound. Acute pancreatitis, very common in all across all ages, pediatrics or adults. And there is a big spectrum of ultrasound of findings, right? You can have little changes just at the tip, at the hilum of the spleen and the pancreas. You can have pseudocysts, various presentations, and you can have patients with different body habitus, and it's very challenging. And of course, they will not go for a repeat redo CTs or anything, and are often maybe they are in the periphery where there is not much CT available, or you are the only one who has to give the diagnosis. So it is possible, and yes, we can do it, and we can do it. Chronic pancreatitis, calcifications, dilated ducts, calculi going down, we can all see. Pseudocysts, we can see. Renal colic, of course, stones can present in anywhere in the entire tract. We will look at it all in detail. In the specific module, you can have calculi in the stone, in the ureter, in the UV junction, and the prostatic urethra, and the bladder neck on the way out. So all these things, how to optimize your image settings, how to get the best out of ultrasound image in the given set of patient habitus and clinical situation. That's the skill of the ultrasonographer. Your machine settings and your menu variability will determine the best outcomes, right? And of course, ovarian torsion, you can see in young females as well. Be open to possibilities of diagnosis. You see enlarged ovary with peripherally displaced edematous follicles, twisted pedicle sign, and size and various other factors give you the cue. Right. And of course, little older children, we are open to possibility of ectopic pregnancy. That's a totally big, huge, detailed topic in itself. Will be covered in appropriate module in gynecology a bit, yes. And then, of course, you look at color Doppler to enhance your diagnosis in cases of ovarian torsion, where you can see the blood flow. You can quantify it as well, and you can document it as well, and it can be used as follow-up. Differentiate in between torsion, detorsion, and tossed and infarcted ovary are going to be discussed in detail. And of course, when you have a blood flow that is there and blood flow that's not there anymore, and when you see it's infarcted, you can see the ovarian margins have like kind of shrunken or collapsed, or heterogeneous kind of margins, right? So you can see those, and then of course other abnormalities you can see in the lungs. They can be presented in this area. Testicular inflammatory, acute inflammatory, and torsion findings can also be seen. In conclusion, so approach and differential diagnosis in pediatric acute abdomen depends on the age of the patient and the associated symptoms. Ultrasound is portable, easily available, and its real-time non-ionizing modality plays an important role in diagnosing, follow-up, guiding further imaging, and so much more. And the acute abdomen mnemonic really gives you an insight to cover and to be open to more possibilities that we are actually widening the coverage area that we can cover by ultrasound imaging. So, of course, a role of clinical history and lab parameters and advising further imaging. All these things must always be considered. And I really, really thank you all for joining in. And I really thank you all for your wonderful interactive questions and your presence. And I invite you all for the full course. Thank you so much. Thank you for the great journey of learning together with all of you. Thank you so much. I'm excited. Thank you so much. Learning is continuous and I'm always there for it. Thank you so much. Thank you to all my institutes, my cases that I've learned from, and for the wonderful images that my colleagues have given from, to all the patients who have allowed me to do the scan and gather such valuable information, cases, images to develop such great tools of learning and my presentation. Thank you so much. If you have any questions, I'm happy to take them. And thank you all for your wonderful, wonderful presence.
Thank you so much, ma'am, for your wonderful lecture. You deliver like always. It's my honor to host your session.
Thank you. Thank you. So we do have a one
Ma'am, we
question.
don't have, yes, ma'am, we have a
There
question.
is one question. How to diagnose mildly exaggerated bowel loops? Okay, so one, whether it's small bowel, one, whether it's large bowel, or whether it's duodenum. So you look at that, and you have to have the proper transverse plane to be able to measure the diameter. So you measure from wall to wall, the serosa to serosa. So 3 millimeters given as a cutoff, but then you have to also see the distension, the wall thickness. So I see the functional, the peristalsis and the stasis more as a cue than the absolute measurement of the diameter, because further it's actually a CT diagnosis. But for me to be able to think in that direction, I would first have to have a proper scan in the perfect position in the plane to measure. And if there is a lot of gas, then I will have to give some fluid and allow it to move so I can at least just have fluid where I can see the anterior and the posterior wall and see it in the proper plane, and then give the measurement and see the peristalsis. And depending upon which area of bowel you are looking at, there's measurements, and we will discuss that all in the detailed class on the bowel diameters and evaluation of the specific areas. So thank you everyone for joining in. And this was truly wonderful experience for me, relearning and resharing with all of you. I learned a lot today. Thank you. Thank you. Over to you, Pooja.
We will get back to you on 18 December with our first session from the series of Abdominal Ultrasound Master Course. Please do registrations to learn more or upgrade your knowledge. Thank you all of you to join. Here we end our today's session.
Thank you, everyone.